So I can't actually see everybody's names from over here, but maybe I'm just going to ask everybody from the panel to just introduce themselves briefly and tell us where they're from. So we'll start with Michel Pellerin, please.
Hi, my name is Michel Pellerin. I'm a heart surgeon at the Montreal Heart Institute. Thank you.
My name is Richard Cook, cardiac surgeon from Vancouver.
Hi, I'm Rob Boone. I'm an interventional cardiologist in Vancouver.
My name's Rob Moss. I'm an echocardiographer from Vancouver.
Stephen Freems, cardiac surgery, Toronto.
Gideon Cohen, cardiac surgeon from Sunnybrook in Toronto.
Eric Cohen, interventional cardiology from Sunnybrook. I'm not related to the guy beside me.
Jean-Bernard Masson, interventional cardiology, Centre Hospitalier Universitaire de Montréal.
So thanks so much. As you can see, we have a very distinguished panel of experts with us. So we're going to let Victor go ahead and present our case.
So, hi, thank you for having me here. It's an honor. It's a case for a discussion about what option do we have for treatment of mitral regurgitation. So we want it to be very interactive, so feel free to stop for discussion. So it's about a 71-year-old male who's still active and still practicing law in New Brunswick. He was referred by his cardiac surgeon for a history of severe symptomatic MR for a mitral clip evaluation. His previous medical history is very morbid obesity with more than 300 pounds, obstructive sleep apnea, diabetes, persistent atrial fibrillation, and ischemic heart disease with the previous PCI and the RCA and CIRC. He describes dyspnea on exertion and rest. He was recently admitted for pulmonary edema, and on the investigation he had no significant restenosis and no other new coronary artery disease. He was considered to be at high risk for surgical intervention in New Brunswick due to risk of postoperative complications. So he was transferred for a mitral clip evaluation. His TTE showed LV function of 50% with a non-dilated LV. He had 4+ MR with flow reversal in the pulmonary vein. His regurgitation volume was 75. Effective regurgitatory fuse of 0.5, mild calcification of the posterior annulus, and mitral valve gradient of 2 and 5.2 mitral valve area. So here's the transesophageal echo, so you can appreciate the mechanism of the mitral regurgitation. Sorry. So we can see some calcification on the posterior annulus extending to P3 leaflets. He had obviously severe MR. He had some restriction of the anterior and the posterior leaflet, as you can see. And it seems to be around A2, P2 that the jet is predominant. So here's the summary of the transesophageal echo. So the case summary, he's a 71-year-old male. He had multiple comorbidities, including, of course, a really morbid obesity, diabetes, symptomatic mitral regurgitation. He had preserved or mild LV dysfunction because of severe MR and LV of 50%. And he's got calcification of the posterior mitral annulus.
Can we just ask, it was reported that, so Don and I are sitting here as non-mitral clip space operators, and it's reported that this is a non-operative patient. Preserved LV function reasonably. He's got good coronary flow. So is he truly a non-operative candidate or just a high-risk operative candidate?
Why don't we go with our panel, the surgeons on the panel. Who would you like to give their impression in terms of how good a surgical candidate that patient is?
Well, I think everybody can be operated on, but sometimes it's not the nicest decision that you can make. I don't think this guy is a complete prohibition to surgery. However, the best option would be the least invasive procedure, according to me, and based on the fact that he had non-structural valve disease, militates in fact towards in minimally invasive, percutaneous intervention for sure. That's my assessment.
Would you be concerned about doing a mini right thoracotomy approach to do conventional mitral valve repair?
This is a very big guy we don't have any CT scan to evaluate the I would say visceral fat in this guy, but I'm sure that the mediastinum is full of grease and the access to the mitral valve would be quite hard even from the right side, which is another concern for sure.
Gideon, what do you think?
Yeah, I would agree. I don't think the comment on the slides were that he was inoperable. I think there's the concerns with respect to morbidity more so and post-operative recovery. I agree that he'd be a difficult operative candidate. He's certainly not inoperable, but exposure would be difficult both in the conventional open approach and minimally invasively, I'm sure. So it's certainly reasonable to consider a percutaneous option in this scenario. You know, the one thing that we struggle with even now in evaluating these patients that are not necessarily inoperable. I mean, the inoperable patients it's quite clear, but the patients that are poor candidates for surgery, the question we always ask ourselves is, well, a percutaneous approach doesn't necessarily preclude surgery after the fact. Try the percutaneous approach. If it works, great. If it doesn't work, well, you still have that surgical option available to you. Albeit not a great option, but still there.
Yeah, I agree with you, Gideon, because I think in particular this guy I think would end up with a mitral valve replacement, given that posterior leaflet is so calcified. So I think if you had a patient who had a highly repairable valve and sent them for a MitraClip, I'd be concerned about that because that might make the valve less repairable. But in this case, I think it'd be completely reasonable to try the MitraClip, and if that fails, then the guy's going to end up with a mitral valve replacement anyways.
Just a comment. The mitral space is interesting in the sense that, there's a wide variety of, let's say, technical expertise from the surgical point of view. From the aortic valve space, I think many surgeons do it extremely well. But from when surgeons perform a surgical mitral valve repair, there's a little bit more art, there's a little bit more technique involved. And so there's the whole aspect of perhaps assessing the risk of the procedure from the surgical side. But then, I'd like to hear maybe Anita's comment, because we also have to assess the risk of the MitraClip procedure. And whether or not it's technically feasible, and what's the likelihood of success, both from patient perspective and also what we'd like to see on echo at the end of the day.
Right, so I'm going to actually shift that question to either Rob or Eric, who also have a substantial MitraClip experience. What do you guys think? We'll start with Rob. Is this a case that you would consider doing by MitraClip? What's your impression?
So just looking at it, there's a few other things that out of completeness, and we talk about the heart team, but there was no review of medications in this discussion, and I think that we always do that. There was no review of the ECG. This is unlikely to be our CRT candidate, but that also should be considered. This guy's complaints are shortness of breath, and he's obese. We haven't heard what his PA pressures are. We don't know what his TR is. We don't know what the right side is doing, and I think we need to know that. So these are other items for discussion. If we're just talking about anatomically, whether MitraClip is feasible in this patient has a number of favorable characteristics, I think, for MitraClip. The anterior and posterior leaflets point downwards, and so for grasping in that area, that's favorable for us. There is calcification that extends from the annulus down the posterior leaflet, and that can create a problem for grasping. I don't think in this case I think the posterior leaflet is long enough that I think that you could get a reasonable grasp, and that would be fine. The posterior leaflet with the calcification there, once you clip the anterior leaflet to the posterior leaflet, you can create the mobility of the valve itself is reduced. And so I don't think this is a significant concern in terms of inducing mitral stenosis, but it is something that I think we consider on a case-by-case basis. Especially with that calcification that's extending downwards. We didn't, or I may have missed it, but the bicommissural view, where we look at the width of the jet. If it's a very, very wide jet, then it will be multiple clips across the jet. And again, that just increases the risk of mitral stenosis. And it may also reduce your chance of having a perfect result. And so you may just go into the procedure accepting moderate MR. Now, in a patient that is truly non-surgical, that's fine. But in a patient that's surgical, if you're going in and you're thinking, oh, I might not be able to reduce the MR down to trace, then I think, again, you have to wonder whether that's the right decision. And so those are just my thoughts
Eric,
off the cuff.
your comments?
Well, I think Rob already said many of them, so I won't repeat those. But I think we spend a lot of time with the technical evaluation, the anatomic evaluation of the valve. When it's ideal, you don't need to spend a lot of time. It's pretty obvious. But this one's not ideal because of the calcification issues you mentioned. And I think we'd spend a lot of time. Gideon mentioned that, you can, one of the potential theoretical advantages, you can attempt a mitral clip, and if you don't get the result you desire, the patient is generally no worse of a surgical candidate than they were before. It's not totally true because the procedure carries some peri-procedural risks. They're relatively low, but in this patient they may not be that low. The other thing that started to come into the thinking these days is we don't really have a wide range of percutaneous implantable mitral valves, but we know that's coming. And once you put a clip on, you more or less exclude a patient from that option down the road. So I think the imperative to be confident you're going to get a reasonable result is changing in the last year or two. We better be more sure of it before we exclude them from another future option. So those are some of the thoughts. There are a couple other things I wrote down is, he's presumably had this for a while, and yet he suddenly gets admitted to hospital in pulmonary edema. And that's true of most patients with mitral regurg. They carry on, and something changes to bring them to attention. And a very careful look for what has happened new. Is it really just generic progression of their underlying disease, or is there an acute event? Are they anemic? Are they ischemic? Are they infected? Something like that. Because that dictates how much success you'd likely have, at least in the short term, with just getting them over some acute inciting event and getting them back to a more stable baseline state.
Maybe Rob Moss is here. He's our echo guy, and I agree with Eric that we spend a lot of time looking at these valves anatomically before we make a decision moving forward, and maybe Rob can make some comments.
Yeah, I just got a couple of comments. I think one thing, it is nice to know the mitral valve area before you start, because that helps a lot with the planning process and figuring out how many clips you can do before you render that valve stenotic. My guess is that his valve area is probably okay. Second thing, I think technically it's really nice if you can get that view where you want to grasp and then show the color jet and the 2D image in the same sort of orientation, the same view, side by side. Then you can figure out actually how much leaflet you've got to get hold of there. And it kind of looks a little bit marginal to me, that there's not a lot of, it looks like the calcium's probably encroached on about half the leaflet length. So that might be an issue. So it would be nice to really know where you want to put the clip and then see how much leaflet is actually there to grasp. And the third point is it's a bit odd that this guy's said to have a normal ventricle. He's presumably got, or a normal volume ventricle, he's presumably got chronic MR. And he's got what looks like a somewhat tethered mitral valve. So I'm a bit surprised the heart's not dilated.
So those are great comments. I actually saw this patient in the clinic with Denis Bouchard. We do the mitral clip clinic together. I don't know if Mark Peltier is still in the audience, but this was a patient actually referred to us by Mark prior to leaving New Brunswick. So Denis, maybe you want to summarize our discussion and the decision that we made.
Yeah, well, I think we tried to, I'm sort of an aggressive surgeon, and I certainly don't refuse people based on weight most of the time, but the guy was extremely smart. He have met heart surgeons before. He has read, and after reviewing the images, we had the feeling that mitral clip was possible. We gave him that information. We gave him the information that we were not against doing heart surgery. It was not a complete contraindication, though it was at high risk. And having him at the center of the discussion, we also bring up front the idea, like Gideon was saying, that we might try the mitral clip, see how good he's doing, see how well he's improving in his quality of life and what he does. No, he's mainly a sedentary man, even if he's still practicing law, and keeping open heart surgery as a second step if needs be. No?
So why don't we go ahead with the case, the rest of the case? So we did decide to proceed with MitraClip, so Victor will present the rest of the case.
So the R team discussion was based on multiple factors. First, the STA score was floating with the intermediate risk. The etiology of the mitral regurgitation was, of course, secondary MR. And the option was surgical repair versus replacement. And we can discuss the surgical result for secondary MR due to ischemia. And the MitraClip option were of a concern because of the leaflet calcification. So the patient was in the clinic. He was reviewed, and then we scheduled the patient for attempt for a MitraClip. 3DT is a very helpful tool to orientate and predict the area of grasping. Transeptal puncture was mid to posterior with a high of 318. And clip was aimed in position to A2P2 as the first attempt. Grasping was hard at the beginning because of the leaflet calcification, as you can see. And the TE were at A2P2, so that's the lateral. And after the first grasp, as you can see, there is a residual important MR on the medial side.
So maybe we'll just stop here and I'll ask Eric and Rob, like, what would you do here? So it wasn't as easy, and we kind of assumed that given the calcification of the posterior annulus. It seemed a little bit harder than we thought to get in the exact spot. So we went in the middle, and this was our first grasp, and this was our result. So what do you think of that, and what would you do at this point?
Well, I think it's pretty good, first of all, considering what you were dealing with to start with. And we have this debate on almost every case, and I don't think we're guided still by much more than hunch. You know, is this as good as we're going to get with this first grasp? Do we leave it and put another clip medial to that? Do we let this one go and try and get a slightly better result with the first clip? You know, we've all got memories of releasing the first grasp and doing a little better, but probably more memories of releasing that and regretting that we ever released it, because so it's not totally benign. I think we've learned to grasp and release and move, because you do something to the valve, and I'm not a surgeon, so I don't play with live valves, but we've seen enough cases where after you grasp and release, things can get worse. And so in general, we try not to, but there are times we do it. I think here, if your gradient's acceptable still, you probably have room to put a second clip medial to the first one. I would have thought from looking at the valve in the first place, it probably needs more than one clip anyway.
So it was 5.2 centimeters squared, the valve area. So Rob, what are your thoughts?
So I agree with everything that's been said. It really depends on how much struggle you have for the first clip. If you struggled a lot, then we tend to accept that first grasp and that first result as long as we've got a significant reduction in MR. When you're putting the second clip, it's easier to put a second clip laterally than it is medially. So this is going to require a second clip to go in the medial position. So in an ideal world, this is something that I might try to move more medial, but again, it depends on how long it took and how much you struggled to get that first clip in position. And I guess the calcification, I wonder how much the calcification played into the difficulty with the positioning of the first clip. And if the problem is that on the medial surface, that's where the calcification is, this may be leading you down the road that you're going to get a suboptimal result. So I guess that's always another decision as well, is are you going to say that, this is not going to be a great result, maybe we shouldn't do anything. I suspect that's not what happened, but that always goes through your mind. So
this was actually a case I did with Michelle Pellerin with me, and so we grasped this, and we thought it was it was an okay result, certainly not optimal. And Michelle kind of bugged me to say, well, can't you just put that a little closer? Like, can't you just move that a little more medial? Just see if you could get a better result by moving it. So that's what we decided to do. It was hard to grasp, but not the hardest one that we've ever done. So we decided, okay, well, we will let it go, and we're going to try to move it. So I'll let Victor go back.
So to summarize, this is all the discussion we had in the cat lab.
Yeah.
And
so here you can actually see that calcified part of the posterior annulus, and so we came right up against it, and you can see we have everything that is leaflet after that calcification, and we got it into the clip, so we were able to get it and close it, and it stayed in, because sometimes what happens is if you grasp on the calcification, it doesn't grip and it wiggles itself out after a few beats. So we needed to be close enough, but not so close that we were not gripping anything per se. And so there's the clip closed. And you can see, again, that calcification is right up to the arm, and we have whatever leaflet there is inside the clip.
the clip was stable. And the result was...
And that was our result.
Amazing.
So I actually think, and I agree with you, Eric, because, I've done over 100 cases now, and I feel like sometimes I still never know what is the best thing to do. And if you'd asked me 3 times, I probably would have come up with 3 different answers. And the first time was, well, maybe I'll leave that and I'll add a second one. And Michelle, who started doing cases with us for about 8 months, sort of said, well, why would you do that? Just move it. And I thought, oh, yeah, just move it. Okay, we'll try. And we actually got a fantastic result. So it was very helpful to have him there helping me along with that.
I was going to say, that shows to me, and I can appreciate the advantage of having a surgeon there. And Brother Gideon next to me here, has been doing the cases since day one, and we alternate. Except that I think in general he has a little more confidence in letting it go and trying to regrasp, and I'm the more cautious, and I think the 2 attitudes play off against each other pretty well. You may come up with the right answer, but having a surgeon there who's actually seen live valves, although they're never moving, right, makes a real difference. So this is a real one for, Eric Horlick was talking this morning about bringing specific skills. I think both skills come to bear really well in this procedure concurrently.
Just a comment because, this is an exceptional result, obviously. It speaks to your experience, but, the surgeons will probably agree with me that being a surgeon, especially a heart surgeon, can be a very lonely profession because it's rare that you have somebody across you that you can bounce. You may have a resident or a fellow, but you rarely have somebody very experienced or experienced as you are to bounce questions off of. What do you do here? What do you do there? Whereas in the cath lab, I find it the exact opposite. I work with Eric, and it's always nice and reassuring and to have somebody to share information with and to ask important questions with and to come up with a consensus.
I would say that my best buddy in the OR is the TEE guy.
I was going to just make that point too, that in the cath lab, we have a TE person that we discuss all this stuff with, and it does help a lot to have someone that you can, share your decisions with.
I just want to add a comment. What would have been the surgical options for? What would have been the surgical options for this guy? We talk about repair, but the only repair that could have been possible in this guy would have been an actual Alfieri stitch. Yeah. So that's why I think considering MitraClip first, because the only option would be if you think about an annuloplasty here, you would have potential problem to anchor it. And then a mitral valve replacement was also an option, but dealing with the calcium is another issue. You won't like to debride the full posterior annulus in this patient. And these kind of operative risks are not well taken care of by guidelines and STS. So I think when you face a complete posterior mitral annulus calcification, it is a serious disease.
In that specific case, I was not under the impression that it was completely calcified posterior annulus like we sometimes see, which are tremendous surgical challenges. So in our decision making, I didn't have in mind that the risk other than the massive obesity of the patient was part of the calculation. But obviously that brings to discussion, repair for functional MR, and we have good results usually in the OR, and then with those failing ventricle and increasing tethering, there's more and more tetherings, and we have MR recurrence. So.
It would have been interesting to maybe poll the audience about what would you have, would this have been your choice if the guy had a prolapse P2 in the same setup? Any or surgeons on board?
I would.
Yes, so at Sunnybrook, most of the patients have FMR, but the best results have really been in patients with degenerative valves, and because the repair is often excellent. At the FMR patients, usually there's some residual MR. The results have gotten better and better with time, but the degenerative patients have often had excellent results. So degenerative is not a contraindication to MitraClip at Sunnybrook.
I would have been tempted to maybe to pay an extra coffee to Anita to discuss conventional surgery for that patient if he had a flailed P2, because I think that the conventional repair gives outstanding results, very durable. I believe in minimally invasive surgery in severe obesity, which decrease, we're going to be discussing that later on in the afternoon, but decrease quite a bit the post-op complications. What about you, Anita? What have been your thoughts if that would have been the prolapse P2?
So that'll cost you a coffee and a cookie, because that's a bit longer. But I think, our practice, at least at the Institute, and I know it's different at Sunnybrook, we don't tend to do a lot of degenerative MR with MitraClip. The majority of our experience is functional for the reasons that you mentioned. The surgical results are so good, can be done at such low risk. Having said that, I think we all understand that given his comorbidities, his operative risk was not insignificant. And I think it's still a reasonable option, except in those cases where you see a real Barlow's, where I just don't feel MitraClip is ideal in Barlow cases. But I still think an isolated flail of a P2 or even an A2 in someone with his surgical risk could be successfully attempted with MitraClip, with in the back of your mind assuming that if that doesn't give you the optimal result, surgery's not off the table. It's still an option. And I think it's not unreasonable to start with a less invasive, lower risk procedure for those patients. So
can I ask, if you have somebody with an isolated P2 prolapse and they go for MitraClip and for whatever reason MitraClip is not successful, it was my impression that that would make the repair of the valve much more difficult or maybe even impossible.
Well,
go ahead.
This is partly coming back to Eric Cohen's comment about releasing or not the leaflet. I've reoperated on few patients, but some that I've reoperated on that actually tear in the posterior leaflet. Those that we tried to grab many times had actually, sort of, the tissue had been fragilized quite a bit. However, if we're dealing with a clip in place and it is an early re-op, there's a small mechanism that if your loops are strong enough, you can actually put the little screwdriver exactly at the right space. It's not like Star Wars, the first episodes, where he needs to go into that very, very, very tiny little hole, and that would release the clip completely. I've not done that. I don't know if other surgeons have released the thing in a live case.
It's not easy.
Have you done it, Gideon?
Yeah, I've attempted it once, but it's not easy. And by the time, it doesn't pull apart easily, and you'll probably end up injuring the valve. I ended up just excising the clip and then reapproximating the free edges, but the valve was still repairable.
Sort of like a small V-shaped resection,
exactly.
and you would just close that V defect.
It was not easy to remove.
Michel, you have done that, right?
I had one case for functional MR that was leaking, and then he was reoperated on about 3 weeks later, and I was able to take 2 hemostats and take it out. And the valve, to my surprise, was not bad, and we just do a mitral reducing annuloplasty of 2 sizes, and it was repairable.
So you did not go through the keyhole. You went through a special Michel Perrin technique. You ripped the clip apart.
No, but very gently. I opened like a crocodile mouth, you know?
Can I pose a question to the surgeon? So let's look at a different scenario. A patient like this with severe functional mitral regurgitation, but take the calcium out of the equation. You know, we're often have to make that difficult decision. It's always difficult for a surgeon to see a perfectly anatomically normal functional MR valve and have to make a decision as to whether to repair or replace. It's hard to replace a valve that looks perfectly normal. And you know, there have been suggestions of looking at the valve, diameter of the annulus, the tenting height, the tenting area, as to guide you as to when to repair versus replace, or what the risk is of long-term failure. How do you decide when to repair or replace a valve which can go either way?
Functional, you mean?
Yeah, functional.
I think all the prospective trials are in favor of doing probably a replacement, but I think there are always on-site evaluation that are hard to pick up in prospective randomized trial, because for me, the anterior-posterior diameter of the valve and the surface of the anterior leaflet is what would dictate me to use an annuloplasty ring, as opposed to a very small valve, 26 size or 28 size. When you go in and you don't do anything, I would preclude to do a repair. But my bias is towards replacement since the trial that were published.
Okay, so that's been a great discussion. I'm just hearing that they're ready to go live at the Montreal Heart Institute.